Good morning. Thanks for being with us today. I'm Dr. Tommy Hysler with the Houston Area Safety Council. Thanks again for being on the webinar today. Very excited to have you, to be able to share some insights with everyone on the call today. The goal of the webinar today is to specifically address the COVID virus as it relates to our workers and our workplaces. So I'm going to flip back and forth between some screens and before I introduce our speakers. The mission of the Houston Safety Council, which is sponsoring this event today, is to build safe workplaces. So HASC, for its part, is doing all that we can to make sure that we're getting all of our workers trained and qualified to enter their job sites, and also caring for any injured employee that may come to see us at our health centers. We're also very grateful to be in collaboration with the University of Texas Health Science Center at Houston School of Public Health. They're offering their subject matter experts today, as well as offering CEU credits for the attendees today. Special thanks to Michelle McDaniel with UT for coordinating those efforts, and we will get those CEUs to you as soon as we can after the webinar. If you live in Texas or the Houston area, I'm sure you all saw Governor Abbott's newest plan to start reopening Texas starting this Friday, along with several other states that are doing the same, some even more aggressively than Texas. So I'm sure that we will talk a little bit about what that means for our workplaces and our workers today on this webinar. I know that's a hot topic right off the press. I know that all of us on this webinar get dozens of calls every day about what to do at work sites or places of business to ensure that workers are free from infection when coming back to work. What should I do? Should I test everybody with an antibody test before I let them back in? Should I make all the workers get the nasal swab? Should I do both? When are those Abbott quick test machines going to come on the market where I can test 1,000 people over the course of several hours? All good questions. All good real scenarios that we all are facing, and the answers to those are not always easily available. The CDC doesn't answer questions like, should I be nasal swabbing every worker before they come onto my site? They just don't answer that right now. It's not on their radar. So to help us answer some of those and to help you navigate through this maze of uncertainty, we wanted to offer this second webinar to our community and our industry. Along the way, if you have questions, please type them into the question box that's on your screen. We'll do our best to answer all of them. And if you were on the last webinar, you know that if we didn't get to your questions, we still answered them and sent them to all of the attendees that registered. So you'll get all the answers. If we can answer them, you're going to get those answers one way or the other. So just be on the lookout over the next several days for that email to come through if we don't get everything answered. Luckily, we do have a great panel of experts today, and let me introduce those to you now. Dr. Bob Emery is Vice President for Safety, Health, and Environment and Risk Management for the University of Texas Health Science Center at Houston and Professor of Occupational Health at the University of Texas School of Public Health. Dr. Emery has more professional titles behind his name than anyone I've ever seen. And we are very honored that he has volunteered his time to be with us today. So thanks for being here, Dr. Emery. Next, have Dr. George Delclos. Dr. Delclos is a professor of occupational and environmental medicine at the University of Texas School of Public Health here in Houston. He is triple board certified in internal medicine, pulmonary medicine, and occupational medicine, and is a treasure trove of knowledge when it comes to occupational medicine and this virus in particular. Our next panelist and special guest is Mr. Mark Briggs. Mark is the area director of OSHA for the South Houston area and has been with OSHA for a whopping 30 years. It's a long time. Mark holds the Certified Safety Professional title and is an industrial engineer by training, and has spent his entire career as a safety engineer, helping us all navigate through our OSHA issues. Mark is very passionate about God, martial arts, leadership, and of course his family. He is here to talk with us today about OSHA's role in this pandemic. I was very happy to see that Washington, D.C. gave the thumbs up for Mark to participate with us today. So if there's any questions specific to OSHA, feel free to type them into the question box, and we will try to answer them quickly as we can. So what I'm going to do now is get Dr. Delclos, George, to share his screen and give us an update on Houston and Texas in general and show where we stand with that. So I'm going to flip that over to you, George, and now you should be the presenter. I think you might be muted, George.
I am. I was.
There we go.
All right. So where did my slides just go a second ago? Let me. I had them up here a second ago. You can see them?
Yes, sir.
Great. Why can't I? Let me see. View everyone, view presenter. Nope, that's me. And what about if I hide the webcams? Okay, how about now? You can see it now?
You can see him, yes, sir.
Okay, great. Thank you. Well, thank you, Dr. Hysler, for inviting me again. As y'all might remember, I also did the last one about a month ago, and it's a pleasure to have been invited back. So just really quick, I only have a few minutes of presentation because we really do want to devote the balance of this webinar to the question and answer session. But just to give everybody an idea of where we are here. Okay, so as of last night, worldwide, there were over 3 million cases of COVID-19 in the world, and over 210,000 deaths. This is from the very beginning. In the United States, again, as of yesterday, there were close to 1 million cases. We may well have passed that today. I haven't checked. With over 55,000 deaths, by far the country with the largest number of cases and the largest number of deaths worldwide. In Texas, around 25,000 cases with 661 deaths. And in the Houston-Harris County area, if you don't count the surrounding counties, just Harris County and the city of Houston, 5,800 cases and 98 deaths as of yesterday. But if you throw in the surrounding counties, it jumps up to around 9,000 cases. So what we have here, this is a data source. It's from the Texas Medical Center and that I've been tracking for a while, and it does reflect data, even though it says Texas Medical Center, it does reflect the data for all of Houston, Harris County, and the surrounding counties that you see in a footnote there. The red line indicates the cumulative, meaning the total number of cases so far, and the blue bars indicate the total increase of COVID-19 positive cases day by day. And we can take that daily total increase in positive cases, and thanks to some of our biostatisticians at the School of Public Health, in particular Dr. Jose Miguel Yamal, who has taken these data and made them into a smoother curve, what we see on this curve, it's very interesting that in March, when our caseload was relatively low until the end of March, Houston started experiencing a big rapid increase in cases until about the week of April 8th or so, and since then has been steadily declining. This is the number of new cases per day, and it's been steadily declining, although that should not be taken to mean that we're hitting zero by any stretch of the imagination. We are still averaging around 200 new cases in our area per day. What's very interesting also in this graph is the red line on the left signifies what the date that the mayor of Houston implemented the shelter in place, the home isolation, if you will, measure, which is a form of social distancing, when it was implemented, and the upper limit of the period of incubation of the virus, so that most cases that had started at the time of the red line, we would have expected that by 2 weeks later, those cases would be reflecting the measures that were in place 2 weeks earlier. And you see clearly that following that green line, the curve starts to go down. This is very, very powerful evidence that the measures that have been put in place are working. We're not out of the woods, but they are working. And so it also underscores the importance of staying at home, and now with the reopening, the importance of social distancing, because staying at home is just one form of social distancing. It's not just the thing about staying 6 feet apart. So this is important. Also, I think to reassure the citizens in the greater Houston area, our hospitals have been planning their response well before the very first case arrived in the U.S. I remember being named to task forces here before January 21st in anticipation of what might be coming and to prepare for worst case scenarios. As we say in public health, we hope for the best, but we try to prepare for the worst. And basically what this slide shows you, there's been a lot of talk in the press about concerns regarding whether our frontline healthcare workers have sufficient personal protective equipment. Through very careful planning and many, many other measures, contingency measures, I'm happy to say that in general, the Texas Medical Center has done a very good job of maintaining an adequate supply of personal protection for our frontline healthcare workers. And in terms of beds availability, y'all have heard a lot about hospital beds or hospitals being at capacity, not enough ICU beds, not enough ventilator beds. Again, through very careful pre-planning and then adjusting day by day the situation, we've been fortunate, at least in the Texas Medical Center, to keep our ICU bed capacity in the green zone. That means well below the level at which we would have to activate what we call our surge capacity and open up areas of the hospitals that are typically devoted for COVID type patients. And the same thing with the number of ventilators, although I won't show that slide. Now, as Dr. Hysler mentioned, over the last week to 10 days, there has been a push both federally as well as from the state of Texas to reopen, to get people back to their workplaces. Some of this has been, well, the first thing that came out was from the White House. The president's plan to open up America again. And as Tommy was mentioning, just yesterday, Governor Abbott came out with more details on his plan or program to open Texas. We can get into the details of those plans through the Q&A. I'm not going to spend a whole lot of time, but you know, one of the important things to keep in our mind is, although both of these plans pursue the same objective, which is to ultimately get everybody back to work, there are some important differences, notably, for example, in the types of businesses that are allowed to reopen and when they are allowed to reopen with respect to the phase that we are in. So keep that in mind. At the University of Texas School of Public Health, Dr. Emery and I also participate on various work groups that are trying to assist both our university as well as the state of Texas on returning to work safely. That's our job. We are public health. And so our goal is that whatever the process is for returning to work, that it be done in as safe a manner as possible, and to reduce opportunities for the virus to interact with us as human beings. And by applying a series of guiding principles, we are working on toolkits and recommendations for industry, specific industries, and also for workers and employers, as well as training of employers and employees. These guiding principles, we think that it is very important, again, we are talking from our role as public health professionals, that any reopening should be driven by science and by public health principles that aim to contain and reduce the spread of COVID-19 in our community as we reopen the economy. Second, that preventive measures at work should follow the traditional occupational health and safety hierarchy of controls. I'll talk a little bit more about that in the next slide. And that finally, whatever we do, whatever measures we implement, that we not ignore the data and what the data are telling us. And so We have to be guided by very close monitoring of local and statewide COVID-19 infection data trends. We need to reassess before we move on to the next phase how things are going, and if we need to delay, for example, moving on to the next phase, or maybe even step back and reinstitute some measures that had since been lifted. By the Occupational Safety and Health Hierarchy of Controls, this is a traditional industrial hygiene approach to safety in the workplace, and I think most of the audience is going to be familiar with these. They can also be applied to the COVID-19 situation. So you know that at the top of the most desirable form of controlling a workplace hazard or exposure is through elimination. So things like working remotely, continuing to work remotely if possible to prevent or limit the virus from entering the workplace, to promptly identify and remove cases that are confirmed COVID-19, to try and institute some method of daily screening of employees and visitors to workplaces so that they don't enter the premise if they have anything suggestive of an active infection, and other COVID removal strategies. The next level in the hierarchy of controls is engineering controls. That means when you can't eliminate the problem, you try and set up barriers or try to implement engineering approaches to control those exposures. So things like what we've been seeing in the supermarkets, sneeze barriers at the cashiers, drive-through windows, a greater emphasis on retail stores using more curbside pickup than actual on-site presence of both clients and employees, and some HVAC technologies. Those are examples of engineering control. Social distancing is a key type of engineering control. Maintaining that minimum of 6 feet of distance in your workplaces, and I would encourage employers to think ahead of time before their employees go to work and look at ways in which they can assure this separation. Cloth face coverings, not respirators, not surgical masks, but cloth face coverings are designed not so much to protect the wearer of the cloth face covering from others, but to protect others from the person wearing the face covering. And in that sense, it's more of a traditional engineering control because it represents a barrier. Administrative controls are things that employers can institute in their work practices to try and decrease the likelihood of spread. Things like training of workers, creating teams of workers, or what are called employee pods, cross-training, working, modifying their shifts to minimize the presence of employees on site to the bare minimum needed to maintain a healthy level of production, modifying workflows, and even assigning a person specifically with charged with the task of administering the COVID policy in a given workplace. And finally, the least desirable, yet still widely used in this case, form of control, which is personal protective equipment through the use of gloves. Here, yes, face masks and face shields, as well as respirators and hand hygiene where appropriate. So that's all I wanted to say. I do want to underscore the importance, again, as I did in the first webinar, that there are many, many sources of information on the internet. As we know, not everything is as reliable or as trustworthy as we would like. And so on this last slide, I present to you some sources that you might want to consider, both case numbers, the very first map that I showed, which I think everybody in the US now recognizes as coming from Johns Hopkins University, as well as guidelines for different scenarios that can serve for both employers and workers on how to get back to work safely. And thank you very much.
Thank you. Hey, George, can you go back to the hierarchy slide? You know,
yes, sir.
because I know I get this question a lot. I'm sure you guys do as well. What do I need to do to make sure my work site is safe and protected? And I think that is an excellent example of things that you can do to prevent your workplace from potentially becoming infected. And I think not only is it good in general, examples of what to do, but it's eye-opening to see that gloves and face shields are the last resort of what you can do to protect your workplace. And I know that oftentimes, we wear a mask and gloves, we think we're protected, we don't have to do anything else. But if you jump to just PPE, you skipped the vast majority of the more important things to do to prevent your workers and yourself.
I agree. And I really want to emphasize the point of, now that things are going to start rolling out, different industries, different types of businesses, now is really the time, if they haven't started already, for employers to think before that first employee sets foot back in the workplace of things that they can do in advance of that return to apply some of these controls that we mentioned here. Especially preserving distance in the workplace. We know that the restaurants, for example, at least in this initial phase in Texas, are going to be returning, but only at 25% capacity. That is a direct reflection of trying to maintain social distancing, at least among the patrons of restaurants.
Right.
And then if things work out by May 18th, and the data support that these efforts are working, then that capacity might will hopefully increase to 50%.
And we do have some questions coming in and about, can we have a copy of that slide or that slide deck, Dr. Delclos?
Sure, you have it.
We will definitely send that out to everybody. Okay, I'm going to change this back to me now. Okay. And make sure I've got the right screen showing. Yep, okay. So let's see here. Now I'm going to go back to this slide here. Let's see, 1 second.
All right, so you can hear, you can hear me? Oh.
We can, Bob. Go ahead and if you want to talk about your slide.
Sure. So I'm Bob Emery. Welcome everyone, and jointly we will all get through this. It's been a long slog, but we'll do okay. My role here as part of this event is to talk a little bit about protective equipment, specifically with regard to respiratory protection, but I'm going to use some specific terminology because we want to be careful in this regard. So, but before we go on, I would like to underscore many of the points that Dr. Delclos made, that we can put all of the respiratory protective equipment out there in the world, but that's at the lower end of the hierarchy of other things that we might be able to do to address this challenge. So for example, the organizations having some system to find out if you're sick or have been sick, stay at home and then work through their employee health or healthcare provider. The notion of social distancing, I think we're going to see a lot of that as these organizations particularly emerge. And then it sounds mundane, but regular hand washing with soap and water or hand sanitizer, that is very, very effective. And that's been shown to be very effective throughout time with regard to public health challenges. But my job today is to just make sure we understand the different masking types. And I'm using the term masking because there are some of these devices, as Dr. Delclos mentioned, that are really intended to keep you from unintentionally shedding the virus to someone else. And so that's why you're seeing a lot of stuff on the news about these cloth or either commercial or homemade devices that one can use. And the intent there is that you may be carrying the virus and not know it. And so from a public health perspective, if we can limit that chain of transmission, that's very powerful. And I believe the current order is for the next 30 days in Harris County, I think, for masking to occur in public. And the recommendation would be, if you have your own mask, let's say you've made it out of cloth, or perhaps some very creative folks have sewn things. It's nice. Some of them are becoming quite entertaining. But to wash those in the sink with hot soapy water, or perhaps throw them in the wash machine, hang them out to dry. That's step number one. For those of you that are in settings where you might have a surgical mask, think about it when you've gone to the doctor or maybe the dentist and they're wearing a surgical mask. This paper substrate for this material is not suitable for reprocessing, so essentially those are going to have to be used and then discarded. But those are not considered to be respiratory protection. In other words, not protecting you from inhalation of something, but rather containing anything that you might emit to the person you're interacting with. And then we get to N95s, and these are in short supply, but the N95 respirator, that's intended to protect the healthcare provider from possible inhalation when they may be performing certain procedures. And so one of the challenges we've had here at the Health Science Center is that the N95s have been in limited supply. So we have to make a decision about who is at highest risk to actually use these devices. So we did a risk assessment, and for example, intubation, if we're treating a patient and they have to insert a device down the patient's throat, that can lead to exhalation of possible disease. So N95s, again, are in limited supply. They're intended to be for single use, but the interesting issue that we've been grappling with is that because they're so short in supply, there have been a series of projects underway to reprocess these devices if they've not been damaged. So imagine a healthcare provider has been, let's say, an anesthesiologist, and they've been taking care of patients all day. If that device is not visibly soiled or damaged, we actually collect those devices and bring them into a room where folks are actually applying a vapor phase hydrogen peroxide to disinfect these devices. And then we actually put a tick mark on them for how often they've been reprocessed. And I believe the current number we're using is 5. I think they're being reprocessed 5 times over. So essentially 5 times the number of PPE devices that we would not normally have had. But again, this is just an interim measure. There are 2 other ways these can be processed. Our colleagues in Nebraska, they are reprocessing masks using UV light. And then there's work underway also associated with dry heat, where the devices, the virus can be inactivated by being heated to 158 degrees Fahrenheit at 30 minutes. So I'll just stop there because I suspect there's going to be a lot of questions coming within this topic, and so I'll
right. There is, and while we're on this slide and you're talking to it, I'll throw out a few questions that were submitted. One question was, certain sites are wanting workers to wear fire-resistant masks inside their gate. So if you can talk a little bit about the options of a fire-resistant type mask and cleaning that mask, what can you tell us, Dr. Emery?
Well, that's a good, I'm writing this one down because I never thought about fire resistance for personal respiratory protection, but I don't know that. I'm gonna have to do a little homework on that one, but
Sure.
I will tell you that the UV light option has been published in a peer-reviewed journal. So we feel confident about that. Vapor phase hydrogen peroxide, similarly, we feel confident about that. We've actually had biological spore indicators put in the room. So I don't know if you're familiar with this, but how you do is you actually put these little test kits out there, you gas the room, and if the biological indicators are inactivated, that gives you assurance that the remainder of the products in that room have been treated. The dry heat piece, there's a paper out of Stanford that says that the dry heat process works, but how it would be put into practice is a project that we're working on as we speak. But I am not familiar with fire resistant. So, but I'll do my best to see if I can answer that question later. But an N95, I don't know about the flammability of an N95. I never thought. Dr. Delclos, would you be able? Have you heard of that one?
No.
Okay.
I mean, unless they're talking about respiratory protection that firefighters wear, for example, such as self-contained breathing air, which is, obviously overkill.
I believe, I'm sorry, I believe the context of that question, because I've gotten that from an OSHA standpoint, is in many of the flammable environments that employees are working at, there's a requirement for them to wear FRCs, flammable retardant clothing. And so if they're wearing a bandana, for lack of a better phrase, around their face, is there such a thing that they could be putting around their face that is like is made of FR material? And what's the dangers and what's the exposure relatedness of wearing an N95 for that matter, or a surgical mask, if they're in a flammable atmosphere and they experience a flash fire.
I can't imagine that one would be able to breathe through fire retardant fabric.
You can. No, you can.
can.
I mean, it's not.
Okay.
Yeah.
Right.
I mean, because some of that space is, when you're talking about that close, that microscopic, that there is space in between the fibers, and so you can breathe through. Like if you held your FRC shirt up, I'm not recommending that. That's not. I'm just saying that, if you put your mouth up to your coveralls, you can breathe through your coveralls. I don't know if I want to run a marathon wearing it, but that is some of the question.
I would not have thought about that. So interested. That's why it's good to do these sorts of webinars to get that. And
I guess there's probably a distinction. We use mask kind of as an umbrella term, but I see several people writing in to say what people are wearing as far as FR face coverings are like the neck warmer gaiters that you can just pull up. So not a mask, but a face covering that can be FRs.
Yeah, I would assume, and the gentleman that we're here with, I think they would probably know the answer, is that would meet this definition of a cloth masking type, right? I mean,
yeah. Again, intended to contain airborne droplets from you, rather than you being in contact with airborne droplets or fomites from others.
Yeah. Right. Let's see here. I think what I'm going to do now is jump over to Mark for a couple of minutes, and we'll continue to answer the questions that are coming through back on definitely on the masks. Mark, can you give us some insight into some things that OSHA's done in the midst of this pandemic? It looks like OSHA's pushed through several directives and guidance documents very quickly, which is probably unusual for OSHA to do things so quickly. So can you give us some insight into that?
Yeah, and I want to thank everybody for giving me this opportunity to be a part of it. I've got a little statement I kind of like to kind of cover. OSHA's official message is employers should take steps to stop the spread of the virus. Remind workers to wash their hands frequently, practice social distancing, and you know what? If you're sick, stay home. Where appropriate, OSHA will enforce requirements under its standards to protect the workers from the virus. And those standards might include things like PPE and the respiratory protection standard. That's just kind of our general guidance. As you look at the OSHA website, one of the websites that I would love to see Dr. George add onto his slide pack is OSHA.gov. We've got a lot of good information that we're working closely with the CDC and trying to develop to help out employers to understand what's going on out there. And like you had said, Tommy, that I've been doing this for 30 years, over 30 years actually, and I've never seen OSHA put out directives and guidance documents as quickly and as thoroughly as we have. And so for an employer, I think it's very wise for you to stay and continue to look at the OSHA.gov website. Right on, it's like every other website that has anything to do with public health right now. The very first thing that you see on the splash screen is COVID-19. So you click on that and it will take you to many of the guidance. And we've got guidance on respirator use. We've got guidance on recordability. We've got guidance on just working with employers, what should they do, the hierarchy of response to it, not necessarily the controls, the IH controls like we had talked about previously, but for the level of worker and the exposure rate to the worker. You know, the hospital workers are of course much greater in contact than, say, you know, just somebody that is working at a grocery store, or maybe even working at a retail store. So please, if I could get one message out to everybody, is you need to be reading it, you need to be checking it, and the information is being updated on a daily, if not multiple times daily basis. So it's front edge, it's cutting edge, and we're just trying to get as many people as we possibly can the information that we can to help during this public crisis.
Excellent. I know there's been a lot of questions on you know, the virus potentially coming into a workplace, potentially infecting other coworkers, and then what does that mean for recordability? So what is the process, Mark, right now for determining work-relatedness and potentially reporting that to OSHA?
Okay, there is a whole guidance document on it. I'm not going to cover it all right now because it's multiple pages, and it gets pretty in depth. But the idea is you need to evaluate, is it a work-related exposure? And if you can evaluate that work-related exposure, then that's going to determine where you go from there. Just an exposure, just a positive testing result of the virus does not make it recordable in and of itself. You have to meet some of the other requirements that any injury or illness would be required to meet. You have to have the work-relatedness, you have to have the exposure, you have to have a hospitalization or some sort of beyond first aid action that would have to go on with that. And so those are the areas that you would go down, and you have to, the employer is going to have to make those determinations. And as the employer makes those determinations, if it gets into a recordability standpoint or a hospitalization standpoint, then it needs to be reported to OSHA. You can dial the 1-800-321-OSHA, file it there. You can go to OSHA.gov and you can file it there. And you will probably get a phone call. You should get a phone call from the local area office. And that area office is primarily, what we're doing is making a determination and talking to the employer and working with the employer to see what controls they had in place. What were they doing? Have they been doing the social distancing? Have they been following the CDC guidelines? Many of the things that Bob and George were talking about, have they been doing those things? And as the employer's been meeting those hierarchy of controls, then we've been moving on from that. Where there hasn't been, we've addressed those items. And there's been a few instances across the country where there's been inspections that have been done, and there's been, you know, unfortunately, you know, as we all know, there has been some worker-related fatalities to that, and there have been inspections that have gone on with those. It's way too early right now to know where the outcome is going with that. So I don't want, you know, and it's not like there's been, you know, a jillion different inspections that have gone on because of this. We are taking each one as individual cases, and there is a lot of communication going on within the OSHA ranks whenever these things have come across our plates, and how they're being addressed and how we're dealing with it.
Sure, and thank you, Mark. And a question came in that I asked you yesterday, just, you know, while we were practicing, that I figured would come up as well. And I know you don't make the laws, you don't make the OSHA regulations. So the question is, since OSHA has previously exempted the common cold and the flu as being work-related illnesses in the workplace, why is COVID not treated the same?
You know, in all honesty, and I'm not trying to give a government answer, this was a decision that was made with medical professionals and occupational medicine personnel out of the national office, and that was the rule that was set down. And so that's the decision that they made. You know, it is what they're saying. And if you look at the standard, there is precedent for us discussing this, and we have had history in the past with other epidemic situations where it has been deemed something that we are looking at and it being recordable. So this isn't an unusual scenario.
Got it. Okay, I'm gonna jump around a little bit and go ahead, Rob.
Just real-time information here. Our colleague who's not on the webinar directly, but is lurking in the background, Dr. Janelle Rios, did a little Googling while we were chatting about this notion of flame retardant face coverings. And I believe she has sent to you a couple of links. It's not like we're endorsing one or the other, but I did not realize, and I apologize for my ignorance, but apparently you can get these face coverings that are actually rated for flame retardants. So if that may help, I'm guessing that, were you able to get an email from her on that, or?
Me?
Yeah, did you get, yeah.
No, I have.
I asked her to send it to you, and I'm just thinking that whatever, you're going to have some subsequent information for the attendees of this webinar, and perhaps some of these links that she just sent may be of use to help people identify that.
And I see that several people have written in with some web links to manufacturers that do offer FR N95 respirators and masks.
Okay.
So we'll disseminate that out to everybody.
Okay, cool, perfect. All right, thank you. All right.
Sure. So here's a question, and maybe geared to Dr. Delclos. Some pressure on some companies when returning workers back to work who are all asymptomatic. What's the value in screening everybody when the test is really only going to be, the test result's valid for that one day you tested them? Would you not have to test them every day of their employment to see if they will contract the virus somewhere down the road?
Okay, well, that's a good question. I think to start off with, we need to separate workplace screening procedures, meaning when you access the workplace every day, from testing, although testing is being discussed as a possible add-on to screening, and we can get to that later. So when I talk about screening at the workplace at job entry, I'm talking about things like temperature checks every day and symptom checks. And granted that a person who is asymptomatic, who has no symptoms, could still be carrying the virus and would easily make it through those controls. That's why you don't limit your interventions and your controls to a single thing. Screening at the workplace should decrease certainly the presence of workers who have symptoms right there, but by itself, it's not going to be enough. So that's why we talk about the other measures: social distancing, face coverings, washing your hands, et cetera, as important measures that are not one's not a substitute for the other. With respect to testing, I think somebody might be typing on their computer there. I was wondering if they could mute. With respect to testing, by testing, I mean testing, doing a COVID-19 test, either a nasal swab or a blood test for antibodies. That is still very much up in the air. It is true that the test result, at least for the nasal swab, only represents your situation that day. You can be negative today and have symptoms tomorrow and start becoming positive. The antibody test is, at this point in time, I don't think it's ready for prime time. This is my opinion. I've looked at the data, the evidence. Antibody testing is being considered in people who have passed the infection or over it, and they have developed antibodies to that infection that may or may not represent that they are immune from, reinfection. The jury's still out on that one. I think, and it's already hit the news of the past several days. So it's not just something that's in the confines of scientific publications. So there are problems with the antibody tests. On the one hand, there are problems with the accuracy of these tests. There are about, at least as of 2 weeks ago, there were about 70 different commercially available antibody tests on the market. Some of these had been okayed in quotation marks by the emergency use act, I think, that FDA has, but that does not mean that FDA had tested and validated them. As a matter of fact, 2 weeks ago, of the 70 commercially available antibody tests on the market, only one had been validated by the FDA. Since then, there are a few more that have been validated. I think as of 2 days ago, there were a total of about 7. So the lack of accuracy of a lot of the tests that are being peddled out there is concerning, because you may get a test that you think is if it's positive, it's protecting you from COVID when there is no evidence that it is, in this case, simply because the test is a bad test. Some of these tests in fine print, you'll see that they tell you that they can't distinguish between this coronavirus and other coronaviruses, including ones that cause the common cold. So test accuracy and validity is very important. But even if you have a valid test, and there's going to be an increasing number of these available, thankfully, we still don't know how to properly interpret them. It is true that the evidence suggests that people who have had an infection, starting at about 1 to 2 weeks after it's over, they start to mount antibody levels, what we call IgG or immunoglobulin G levels, which for many diseases, a high level of IgG, of this type of antibody, does mean that you are protected, sometimes for life. If we take the measles, for example, when we check to see if somebody is immune to measles, that's what we measure in their blood, the IgG level. But that doesn't mean that this is applicable to COVID. There's not enough of a track record yet to know. It is likely, but we still have to prove it, that having had COVID does confer a little bit, does protect you at least to some degree. Now, whether that protection, that immunity lasts a few weeks, a few months, many months, or is lifelong has yet to be determined. So I'd be very cautious, and I have heard that some employers are considering using this antibody test at the workplace as a way of deciding who gets to work and who should stay home. And even though it's done with good intent, I would caution that based on the science that we have right now, it could not only be non-productive, it could be actually dangerous, because you are assuming that people who might be protected, in fact, are not, and you're allowing them to return to the workplace, and vice versa.
Dr. Delclos, it's Bob. Just real quick, there's a reason this thing was called a novel coronavirus, and I'm wondering if maybe some of the uncertainties that you're describing there, I'm hoping that the attendees of this webinar will appreciate that concept.
Right. So coronavirus is a family of viruses. And like in any family, you have some good kids and you have some that aren't that good sometimes. But there are about 7 of these, if I remember correctly. Of the 7, 4 or so of the coronaviruses are responsible for the common cold. And the other 3 have to do with the preceding epidemics. So y'all have heard about SARS, that was in 2003, I believe, had a very high mortality rate, and fortunately didn't spread anywhere near how novel coronavirus is spreading, how COVID is spreading. And then a few years later, we had the MERS, which is also a coronavirus with the same family, and started or mainly hit its peak in the Middle East. SARS in 2003 started in China, and MERS was more of a Middle Eastern thing. And SARS-CoV-2, which is the actual name of the virus. When we say COVID-19, we're talking about the disease, the infection, but the virus itself is called SARS-CoV-2, is a member of this same family, but there are important differences, and it has to do with the genetic structure of this virus. Some of the parts are different from the others, so you can't assume that just because they all belong to the same family that they're going to behave the same way.
Excellent, thank you. A question, Dr. Delclos, from one of our medical colleagues. Seeing, and I can speak to this, on a personal nature with some of my patients, continuing to nasal PCR test, doing the true nasal swab, sending it off to the lab, finding a patient that is positive, and you continue to test them because that's the guidance, the guidelines say if you can repeat test them, great, right? Test them to see when it's negative. Some of those tests still coming back positive after 6 weeks. after that person has become infected. I had a patient myself, 6 weeks later, no symptoms, you know, a month has gone by, no symptoms, completely healed. That test is still coming back positive. So should we rely more on that test result or the fact that it's been a month since they've had signs and symptoms?
That's a great question. So just as a little bit of background, at least in the healthcare sector, which is where more of these return to work tests are being done in people who have had the infection. If you look at the CDC guidelines, it offers healthcare workers and their employers two routes. One is called the test-based return to work strategy, and the other is called the symptom-based return to work strategy. The test-based strategy, and CDC says is the more desirable of the two because you have some objective evidence, whereas the symptom-based strategy is for use in those situations where testing may not be as readily available. At the medical center, you know, most but not all of the institutions are using the test-based return to work strategy, and we are at UTHealth, and it involves, just for folks that don't know, that you have, after you've been confirmed to have the COVID infection, and this is important, this is only on confirmed cases, and they've pretty much gotten over it, when can they return to work? That's determined by not having fever and not having symptoms, or at least having marked improvement of symptoms for at least 24 hours, and subjecting themselves to 2 of these nasal swabs at least 24 hours apart, and they both have to be negative. That's an added layer of protection. But it's true what Dr. Hysler is saying, that some people, even well after they've been without symptoms and without fever for several weeks, they continue to be positive several weeks out. Your record is 6 weeks, mine so far is around 5.5. So we do have these folks. It is incredibly frustrating for them because they want to get back to work, especially, you know, doctors and nurses are very gung-ho to get back to taking care of their patients generally, and they're frustrated because they keep on being positive. So what is the positive? Why are they staying positive? What we think, well, first thing, we know that the PCR test, the one that looks at the viral RNA, it's extremely sensitive. So we will pick up fragments of virus, RNA fragments of virus, even though the virus may not be active. It may be on dead cells, etc., and it'll give you a positive test. So it is conceived. What we don't know is if being positive this far out, this many weeks, if that also means that you continue to be infectious. We simply don't know. And so, you know, some groups prefer to err on the side of caution and say, well, you know, since we don't know, we're going to wait for you to be negative. There are other places that are using the symptom-based where there is no testing involved, but, you know, they're also taking a theoretical risk as well, because without testing, they're returning people to work who may not have fever or symptoms for several days. For all we know, they might be asymptomatic shedders of this virus. And then there are some institutions that are instituting sort of protocols in between. You know, they're setting a maximum limit of time during which a person may remain positive, and after several weeks they finally say, okay, we draw the line here, and we're going to let them come back even though we know that they're still positive. We don't know if that means that they're contagious or not. We're going to super cover them with personal protective equipment. We're going to make sure that they, at least in healthcare, don't handle patients who are immune compromised or more vulnerable, and then we're going to have them scrupulously monitor their temperature and symptoms for another 14 days after they get back to work. So there are many different approaches. At UTHealth, we are currently following or preferring the test-based approach. But, you know, it's a pain in the neck because some of these folks may be tested every few days. And you know, we call it a nasal swab. It is not a nasal swab. It's a nasopharyngeal swab. That means it's not a little Q-tip that you put at the tip of your nose. It's something that's basically pushed in all the way back, and when they hit the wall, which is the back of your throat, that's the pharynx. So it is unpleasant, it is uncomfortable, but that's the way to get a good specimen, at least with the techniques that we have right now.
Thank you, George. Appreciate it. A couple of questions on masks. Dr. Emery, what type of a mask do you recommend for manual labor or outdoor jobs in the summer months?
Good question. You certainly can go with the cloth mask. Now that I've been educated on fire resistant, I suppose. Especially outdoors, where you just inherently you have more air movement. So I would think of either a homemade cloth mask or commercial cloth mask, or if you wanted to use a surgical mask and then just dispose of that one, you could achieve the goals of minimizing transmission in that regard.
Okay. And for
Can I add
office, go ahead.
Yeah, I was just going to add, Tommy, that remember that there are outdoor construction workers that for specific tasks that they do, higher levels of protection, including an N95, might be warranted. So for example, certain painting jobs, and it's not because of the virus, it's because of the type of task that they are doing.
Right.
For sure, anything from sandblasting to grinding to whatever, the respiratory protection that one might use for those tasks would be certainly appropriate as well.
Sure, and I'll tag onto that one a question probably geared to Mark and all three of you really. What can you clarify the OSHA guidance document on fit testing? And I think it was just specific to N95s, but what did OSHA say about fit testing right now for respirators?
Well, for the it's primarily for the N95s and the P100s. It's not necessarily for half mask respirators or for full face respirators. So you can't utilize those fit testing protocols for that. This was just primarily for the those types of situations, because we all of a sudden had everybody needing to wear these things, right. And it was very, very difficult to get the testing done and get it done timely and things like that. This was an emergency use situation, so that's what that's for. You can't I can't really think of a situation, but if you were going to have somebody that was going to be sandblasting today, as you hired him to do sandblasting, you've got to get him fit tested for the respirator if the task calls for it, and the type of respirator that they would be using for that situation. This wasn't a blanket, hey, I'm going to be putting people in SCBAs to do confined space entry. I'm not going to have to test them anymore. That's not what that was intended for.
Yeah, and specifically the more common way to fit test an N95 is to poke a hole through it and basically ruin it to do the test. So that's another reason that OSHA stated that don't do that right now. We've got a limited quantity of these masks. Don't destroy them by doing fit tests on them.
Yeah, Bob gives you two thumbs up. You get two thumbs up for that one.
That's not what we want, and that's not what that's something we're in a unique situation here, and those a lot of those guidance documents everybody needs to be aware of. They have a shelf life, beyond the respirator shelf life. The guidance document's going to have a shelf life too. And whenever we kind of get past this crisis, these will be retracted. So 12 years from now, when you're talking to the next area director, don't pull out this guidance document saying, well, I didn't have to test them for it. So
same topic of masks. What should office clerical workers be using right now? Just any face covering at all? Should they be wearing any type of specific mask if they're working in an office setting with coworkers around them?
I'll tell you, and best way to answer that is, let me tell you what we're doing here at the Health Science Center. We have 17,000 people between students, faculty, staff, and others in a variety of settings. But for the folks in the office settings, it's cloth masks, but if they don't, either homemade or purchased, but if they don't have it, we are issuing these, I don't have it right in front of me, these paper, the paper masks, the surgical masks there. That's what through our group, working with Dr. Delclos and others, that has been the risk assessment that we've performed on that. And by the way, I just encounter a lot of people with these paper masks, but they don't have it over their nose. They have it down below. So it's kind of important to make sure it's over both intakes there.
And a follow-up question to that was, are cloth masks considered respiratory protection?
No, they aren't. Their primary intent is to keep you from inadvertently sharing the virus, if you happen to have it, with others. It is not intended to filter out the virus coming into you from the environment or another individual. And I think that's one of the challenges we face here, is that the optics of a mask, which everyone on this webinar is seeing, right? You're seeing them in the stores and out in the public and everything. So I think many people inadvertently lump all of these masks, and I'm using that term generic, that mask, they're being lumped all together, but they're not the same with regard to their intention. That the cloth mask is intended, or homemade or commercial or whatever, and the surgical mask is intended to contain any viral emissions that you might have to others, because you may not know, as Dr. Delclos mentioned, you may not know that you're infected at the time. Whereas the N95 and other devices like that PAPR are designed to protect that individual from inhaling the virus.
Okay. A question, it looks very specific to Dr. Emery. Where do FFP2 masks fit in?
I have no earthly idea. Was that a quiz question that
I got that one. I got that one.
Oh,
I know what it is.
Wow, this is like a game show.
Yeah. Do I have to respond in the form of a question? So FFP is the European designation for an N95. It's face filtering piece 2, and an FFP3 is an N99.
Interesting. Okay.
So was someone submitting that question just to jerk my chain, or were they?
They knew you weren't going to know it.
I'm sorry, Bob. I just couldn't help it.
Thanks for your support, colleagues.
I did see, to follow up on that, because I know there was some questions about, can we use European masks? Can we use the KN95s from Asia? And I did see where the government said, yeah, we'll go ahead and allow those. We'll bless them at this point to be used, simply because there's just not enough in the United States right now.
Yes.
All righty. A point that somebody brought up, not necessarily a question, but a great point, was when we put in these physical barriers and sneeze guards, we also have to make sure that we're cleaning those as well. So if people are just sneezing and coughing all day, but we're not keeping those clean, we've kind of defeated the purpose. So knowing what to clean, how often to clean, and again, knowing what PPE you need for that job is still important and key.
And I would add that that's especially important for the face cover, the cloth face coverings. Bob mentioned the importance of washing it daily. With the humidity coming around, these things are going to get moist, and the more moist they get, the more likely you are to touch it with your fingers. And if, when you adjust these things, you're typically going to be touching it and pushing it against your nose and mouth, and that could actually be counterproductive. So it's very simple to do, but you have to wash them in hot water by the end of each day.
George, this was the same question.
I'm sorry, Tommy, just
go ahead.
Something along that lines, just something he had said made me want to just kind of bring up this point. And the other thing is, at our work sites, we need to be making sure we've got water, we've got ways to wash hands, we've got soap that they can be used. I heard earlier on, I haven't heard it recently, but I heard earlier on people were stealing soaps and stuff like that. Hopefully that's all kind of, the hoarding aspects of all of this has kind of started going down. But the employers need to be aware that this needs to be something that's put on a regular check to make sure that soap dispensers are getting refilled, and there's adequate water supplies and stuff like that. And you need to it's almost kind of like we deal with the heat illness aspects of it. You have to tell somebody to take a drink of water, and we are all adults and we all know that, but we also need to be telling them, hey, go wash your hands. Wash your hands frequently throughout the day, and that's a major factor in all of this, especially as we're working closer together. And one of the things that we're hearing a lot in our office is we don't have any soap, we don't have any water, and it's something that I know it's difficult, and it's probably a logistics nightmare to some extent, but it's something that if you can help yourself along that way, especially if you've got large number of workers in a concentrated area, or even your warehouse people out in the back, those things need to be provided and worked through.
Thank you, guys. George, this was a question that you answered on our last webinar, but it's still a good one. What is the protection factor of a HEPA filter or HEPA filter? Can that protect us against this virus?
Well, an N95, which is not a HEPA mask, is designed to filter out 95% of particulates, of very tiny microscopic particles that are 10 microns in diameter. Remember, a micron is 1/1000th of a millimeter and much too small to be seen by the naked eye. But to filter that out below 10 microns, because that's the size of particles that is more likely to penetrate deep into the lungs, to the bottommost parts of the lungs. A HEPA filter is designed to provide even higher filtering protection. It's designed to filter out 99.97% of particulates with a median aerodynamic diameter of 10 microns or less. So the answer would be presumably yes, it should be. It's a higher level of protection, but that's different from saying it's necessary.
Yep. Along the same lines there, someone asked, should outside air supply be used going forward in buildings rather than circulating its own internal air?
Who wants to take that one?
Huh?
Who wants to take that one?
I suppose it's all outside air coming in,
okay,
right?
well, so let me tell you, for the last couple of months, it's just been a series of insolvable questions, right? But I'll tell you at least my best advice, because we just completed a project with a doctoral student here looking at air room changes per hour and the associated risks depending on what the activities are that are carried out. And so at the end of the day, my advice is I'm looking for my piece of paper here, but 4 to 6 room changes per hour appears to be a good recommendation. But here's where you get into the issue, and that is where the air changes circulate on and off for energy conservation modes. And so I was just on a call, and I think Dr. Delclos and I will be on future calls on this with organizations that are attempting to reopen. One of the issues that they need to consider is this notion of air exchanges, in addition to the social distancing. So if you oh, here it is, I found my piece of paper. Yeah, 4 to 6 room changes per hour. But just for the people that are on this webinar, what to expect when you perhaps go to a restaurant. You're going to see, as people have described, perhaps you drive up, maybe you have to make reservations ahead of time. There'll be the plexiglass shield where you check in. They've removed some of the tables so that there's spacing. Hopefully they aren't stacking all those tables in the back in front of the fire exit. Another issue there. But something as simple as the do they have menus? Do salt and pepper shakers? These sorts of things. But one of the things behind the scene is the air changes within that restaurant. And so our recommendation, again, we're in a new environment, but our recommendation has been 4 to 6 air changes per hour but don't let that thing cycle off for temperature control. So in other words, keep the fan going, but you don't have to run the chiller or the heater, so to speak. Is that making sense? Or yeah,
I think so. I think so.
Yeah, you know, there's an old industrial hygiene principle that's very applicable here, and that's people need to remember that there's a difference between the term ventilation and the term recirculation. So ventilation is exactly what you were describing, Tommy, which is replacement of indoor air by fresh outdoor air. And so that when Bob is talking about the number of exchanges, that's what he's referring to, the number of times per hour that the entire volume of air in a room is exchanged, replaced with fresh air. That's different from recirculation. Recirculation, if you take a room and completely close it off and you put a fan in the room and nothing else, there is no circulating air at all, that fan will actually stir up particles and do the opposite of what you would like to do, which is to keep particulates suspended in air longer. You know, if they're suspended in air, then the likelihood that you will breathe them in is increased. So recirculation and ventilation or air exchanges are two very, very different things.
Thank you, guys. Here's a question about disposing of paper masks. Should paper masks only be disposed of in a bio container, or is it okay to just throw them in the trash?
Here at the Health Science Center, it's been in the normal municipal trash because you don't know for certain. I mean, there's actually definitions for medical waste about upon compression and that sort of thing. So I don't think it's necessary to unless the device became physically soiled with, you know, some biological material or something like that. But other than that, I just regular trash. Dr. Delclos or Mark, or would you guys agree?
Yep.
Could the N95 be put in an oven set at 160 degrees for 30 minutes to sterilize?
We believe that to be the case, but I don't know now that you guys have given me religion about flammability. But that's exactly what we're exploring with an unusual collaboration between NASA, Harris County Health Department, and Whirlpool, where looking at that third option, the thing about the three options, the three big options of reprocessing N95 would be UV light, which we got published papers on, vapor phase hydrogen peroxide, we got published papers on that. The heat aspect, what you're describing, there's a published paper out of Stanford, but what the part they don't know is does the heating impact the ability of the protective device to continue providing that level of protection that Dr. Delclos described. So more information forthcoming on that, but this could be a low-cost solution for many people, and that's why we're pretty excited about it, is that essentially you could have a convection oven set at 158 degrees Fahrenheit and bake it for 30 minutes, and it could be disinfected and available for reuse if it's not damaged. But I put an asterisk next to that one because that's still one in the hopper, so to speak.
And I know that there was a big announcement from the Homeland Security Science and Technology Center that was last week about UV and their findings on ultraviolet light killing the virus pretty quickly.
Yes.
Can you talk a little bit about that, Dr. Emery, and how that relates to maybe cleaning masks or the virus in general?
Yeah. So what? So for years, if someone goes into the hospital and has an infectious disease, and then they've taken care of the patient and they bring them out, there are these devices that you can push into the room to disinfect them by. It looks like a tower. Imagine a tower with maybe 6 to 8 UV light things like imagine like these what do you call them, fluorescent lights that you have in your office setting, right? And it almost looks like a teepee. And that device is put in the room and then allowed to, for lack of a better term, irradiate the room, because some of these viruses are quite susceptible to ultraviolet light, and hence why they don't survive long out in the environment, by the way. I would underscore that. That's an important point. So what our colleagues in Nebraska did was they said, hey, can we use the same thing because we're running into a pinch on these N95s? So they set up a room where they got metal racks, almost like if you would store in the backside of a kitchen area, and they put the N95s in there, and then they roll this, imagine R2D2 that goes in with UV light poles on it, and they actually had biological spore indicators, and they were able to successfully disinfect the N95s without damaging the integrity of the N95 and its effectiveness. So, but there are some issues, and not everybody can afford one of these things. Number one, there are now commercial firms that are coming out saying we can provide this service where after hours we can come in and send in the UV robot. So imagine something like a daycare, for example, or a nursing home, good example. So I think you're going to see more and more of that. But the big three that I've been involved with: UV light, vapor phase hydrogen peroxide, and this thermal heat piece. The thermal heat piece we're still working on, but that's some options there.
Okay, thank you.
Tommy, can I interject something real quick? So, you know, I've observed that what typically happens when one talks about the hierarchy of controls is that most of the questions focus on personal protective equipment, and that's been the case so far here. Even though we were really stressing the point that it is the least desirable form of control. So I was wondering, are there questions that deal more with the other types of controls? You know, Bob mentioned sneeze barriers or other things that employers can do, especially from the standpoint of administrative controls, that I know we're toward the final minutes of the webinar that I thought might be also good to cover.
Sure.
And that's understandable because PPE are the most visible forms of control. You know, when you see protection, everybody thinks about a mask.
The optics on that stuff is huge.
So not that I've seen yet. I'm still scrolling through some of them. But we do have, I think, 13 minutes left. So let's try to do kind of a lightning round to knock some of these out. This one, it looks like, where did it go? To Mark on a record keeping standpoint. Let's say that we find an employee to potentially have contracted the virus in the workplace. We go through our motions. We go ahead and record it. And the question is, do we use the same process of redlining that on the log if we then later determine this was not work related?
Yes, that would be perfectly acceptable. Yes.
Okay, excellent. Let's see here. Anticipating another.
Just before you, I'm sorry, just real quick. I mean, obviously, be sure you document why you're redlining it, and you know, because the thing is going to be is 3 years from now, 5 years from now, some court case or something you're going to be dealing with. Probably not an OSHA thing, but something you're dealing with. You're going to have to be able to go back and recollect why you did what you did, and who knows, all those people could be gone by that time. But definitely it'd be perfectly fine for you to redline if you've got new information that changed your perspective.
Okay. Anticipating that there's a resurgence in number of cases, let's say later on in the flu season, maybe for Dr. Delclos, how confident are we that we are prepared and ready for another resurgence of the virus?
Well, you know, the first step is at least being aware of that possibility, because by being aware, it also allows you to put plans in place to prepare for it. And even though it seems like it's been ages, we've really learned a tremendous amount about this virus in the short period span of 3 months. I think there are a lot of lessons learned about what to do the next time around, and we need to apply those. It is true that certainly in the greater Houston area, the fall months, there are competing infections and circumstances that make it difficult to sometimes to tease out COVID from things like the flu or things like simple allergies. However, I expect I'm not going to even say I hope anymore. I expect that by the fall, we have a much better handle on the patterns of the natural history of this infection and the testing for it, the specificity of the testing that will allow us to make those distinctions a lot better. But we need to be prepared for it, sure.
Okay. A question geared toward Mark. If a U.S. citizen travels internationally outside of an OSHA jurisdiction and contracts COVID while they're overseas working, if they come back here and require hospitalization or some form of medical treatment beyond first aid, is that considered an OSHA recordable event?
That's a good question. I'm going to have to go back and look at the home away from home aspects of it. That depending on how they contracted it, it may or may not make it recordable. Let me put a star by that one, and I'll run that down and get an answer back to everybody on that one for sure.
Sure.
You know, we had a case where an employee would travel to another state and got it at the very beginning of this. It was really the first phone call that we had on it. Got it at a meeting, and he wasn't patient zero. There was people at that meeting that came down with it after that meeting, is why the company made the decision they were making, and I kind of agreed with them. It might, well, let me do some checking on that. I hate to give some bad information. I think from a safe standpoint, go ahead and record it and we can redline it later.
Sure.
So, hey, Dr. Hysler, this has become a popular talk show because now I even got a question here.
Yeah.
But an interesting point that this is, I think, Dr. Whitehead sending this. I don't think the text in the webinar is working, but he did want me to remind folks that many N95s and industrial half masks have exhalation valves. You know, it's that little flappy valve. And the reason we bring that up, the reason it's an important point is that that's why this heating option, we want to make sure that it doesn't damage that flapping valve. But also his point is the exhalation valves do not filter expired air and could release droplets. So kind of circling back to the main point that these cloth masks and the face coverings are intended to entrap droplets so that you don't infect others, whereas the N95 is intended to protect the individual, but with an exhalation valve, you could be releasing airborne droplets. And so anyhow, so kudos to Dr. Whitehead. We'll give him extra
Good
credit.
point, yes. And I do see it on the question list here. I just hadn't got to it yet.
Oh, okay.
Thank
All
you,
right.
Dr. Whitehead.
Sorry, I was rushing batters, I guess.
No. And I probably wouldn't have been able to interpret his question anyway, so I'm glad you did.
Okay.
Let's see here. Maybe a question for George. Is there any HIPAA protection when you're contract tracing?
Yes. I mean, in general, for example, when we do contact tracing through the university, the type of software that we use to help guide us and all that is all HIPAA compliant. But more importantly, the general principle is when we notify somebody who may have been exposed to a confirmed case, we never say who that case was to protect privacy and confidentiality. So typically we will say, we're contacting you because you may have been exposed to a COVID positive person. We don't even say if it's a patient or an employee. And then here are the next steps to take. So yes, there are HIPAA protections for that.
Okay. Let's see here. I'm trying to read as we go here. Just a few more questions, actually. Is there any liability in employers mandating their workers wear masks? I know we don't have any attorneys on the panel, but has anybody run into any problems in that regard?
No. if you give me well, if you can go on to another question, I do know where to find the answer. That I think that they can require them, but let me double check that because we just had an opinion from our legal office yesterday, and I need to look for it here real quick.
Okay. Let's see here. Let's see. A lot of these are for more geared towards George. Let's see. You know, a lot of questions on testing. You know, back to how do I get my employees back to work? You know, full blown back to work if I don't have access to testing. And you know, testing is still very limited in a lot of areas. And the guidance is still to test sick people. So the guidance is really not out there to test everybody or to test, you know, all asymptomatic people right now. So I feel your pain. There's just not a lot of testing capabilities out there at this particular time. And like George said, the ones that are there are not very comfortable. In fact, they're somewhat painful. So it's a quagmire that people are in right now. To what can I do to assure my employees are not infected, are safe to come back to work? And it's a hard path to navigate. George, did you want to add anything to that?
Yeah, I did want to add something. So in our recommendations to the state about how to roll out this reopening Texas plan, you know, again, we are the public health. We wear the public health hat, and we want to make sure that people can return safely. But coupled with a successful reopening, we are insisting that the testing capacity must increase tremendously. And that's going to be very important. I don't know if it will reach the point where every single employer will have at their ready disposal, you know, testing. There are certainly sites around town now run by the health department that basically are opening up to anybody who wants to be tested anytime can do so. There's some issues regarding how quickly they can return the results and all of that. I'm also pretty sure that there will be in the toolbox sets that come out some guidance for employers who do not have ready access for testing on ways that they can more safely return their employees even if they don't have the tests. I anticipate that will be the case. It may well be modeled after the guidance that CDC has provided for returning healthcare workers to work.
Gotcha. You know, and I would also say, I see our colleague, Dr. Maida, texted in and said, you know, to make sure you look at Harris County websites and they'll tell you where public testing sites are available and open, and more of those testing sites are now offering to test anybody regardless of symptoms. So just another avenue to look at. You know what, guys, we answered most questions. I think maybe we have about 15 that we did not, and I will make sure that I get those questions to you guys so you can help me answer those and disseminate the questions.
Yeah, and I'll give
question. Go ahead.
I'll give you the answer about the legal issue, probably offline later, but I have it, and okay. Employers can actually require a fair number of things.
Okay, that's good. Another question, can an employee refuse to be temperature screened upon entering a work site? So maybe that will help answer that as well. Can COVID-19 be spread through smoking?
Well, you know, there's been some discussion of COVID and smoking, even finding the opposite. I want to say smoking is healthy for you because it's associated with lower rates of COVID infection, which is different from transmission. But, you know, and I would just, I'm going to use my professional experience on this one because I haven't seen it written down. But, you know, people who smoke heavily cough. And when you cough, that's a method of spread of droplets. So I would say that it probably does not decrease the likelihood of spreading infection.
All right, guys, it is 1 o'clock on the nose. I'm going to be respectful of everybody's time. I see we have just under 400 people still on the webinar listening in, so that's a huge success. On behalf of the University of Texas School of Public Health and the Houston Area Safety Council, thank you to everybody for attending. Thank you to our panelists, a true expert panel, and I appreciate everybody's time, and we'll see if we can do one again soon.
Thank you for the invitation, Tommy. It was a pleasure.
Thank you, guys. Appreciate it.
See ya.